None of the content on this or any episode of the Kratom Science podcast, Kratom Science Journal Club, or on any page of kratomscience.com is intended, nor should it be considered, medical claims or medical advice. This is the Kratom Science podcast. I'm your host, Brian Gallagher, blog and social media writer for kratomscience.com. Your source for all things Kratom. My guest for the second time on the Kratom Science podcast is Dr. Cornel Stanciu. He's an addiction psychiatrist at Dartmouth Geisel School of Medicine. He's running a new Kratom survey for Kratom consumers. There's a link in the description. It's anonymous, and it only takes 3 minutes. You have a new survey for Kratom consumers, and I'll have a link in the description, so anybody that wants to take this survey can just look in the description of the podcast and take it. If you would just talk about the survey and what you're looking for here.
I guess it might help to for those who are not familiar with what I do. Just to provide
Sure.
a little bit of background, I'm an addiction psychiatrist. I am primarily clinically based, so I interact patients rather than strongly being involved in laboratory research. And I do have a strong interest in pretty much all aspects of Kratom and the impact that it does have on the patients that I work with, those that have psychiatric and addictive disorders. My interest began about 10 years ago, and that's when I first started seeing patients who are Kratom consumers. And throughout the course of the last years, it just really put me down this path of just wanting to know more, everything that there is out there on the topic, to where I started contributing to the literature, doing some studies, publishing articles. And I guess in recent years, I've become relied more upon for my expertise among the medical community. I've consulted in some cases, and also have been invited to conferences to help disseminate information on Kratom to fellow colleagues in other specialties. Now, this particular survey that I'm looking to get some help with, it's always a fine line how much information to really disclose in a way not to influence the participants' responses. But it's really meant to provide more insight into the impact of Kratom on consumers, both good and bad.
Mm-hmm.
What I'm looking to gain here is more of an understanding of how individuals are consuming Kratom, what they're using it for, what are the benefits, what are the adverse effects or any side effects, what is the overall impact that Kratom had on their lives. And I also want to learn more about the individual's background. Do they have any comorbid psychiatric conditions, any addictive disorders? And also, I'm hoping that I'll be able to also gain a better understanding of where Kratom consumers are located around the country. One of the questions in the survey will ask about the first 3 digits of the zip code. Just full disclosure, this is a 100% anonymous survey. No information will ever be able to trace it back to the individual survey participant.
Mm-hmm.
But this first few digits of the zip code will really be able to hopefully allow us to map where they're located around the country. So it's a brief survey, and I'm really hoping to have some good participation going, so we can all expand what we know on Kratom.
Yeah, and this is just for your university, right?
Yeah. So I'm an assistant professor at Dartmouth Geisel School of Medicine. This study was vetted through their institutional review board. I would say it's more because of my interest in the topic rather than part of any institutional incentive, and it's not done for the purpose of providing information for any regulatory board or anyone that's looking to classify or ban Kratom. Just trying to reach out to all current Kratom consumers rather than just a proportion who's looking to participate in this type of scientific studies or who are recruited via other modalities.
Yeah, we should say that, even if you had a good experience, bad experience, you should take it so we can get you can get a complete picture. It seems like some of the surveys kind of, and you looked at this in your papers, they sometimes have a bias because people who are having a good experience are more likely to take them. Is that right?
Absolutely. I did look at some of the literature concerning harm reduction, concerning the, so to say, overdose or poisoning risk. Certainly, as I'm sure you know, there's different layers to scientific literature. You have more of the expert opinions, anecdotal reports, case reports, going up into more of the randomized controlled trials, meta-analysis, and then the highest level, the actual systemic reviews of the literature, which looks at all these layers. And when it comes to kratom, obviously the case reports involve clinical settings, and myself included. Patients don't come to me to say, "Hey, I'm doing great on kratom." They come to me because either they've experienced some type of adverse effect, or they're looking to get help in coming off. So that's part of what generates those case reports. So I would say they are a little bit biased more towards the risks. Observational studies, depends who's conducting it. Obviously, there would be some type of bias if those who derived benefit are the only ones participating, and it's based on subjective report. And at the same time, there's bias if it's based just on reports that have been filed with various agencies. So there's biases everywhere.
Yeah, I took the survey as well, and there's an opportunity to provide a written answer if none of the choices apply to you. I think because the one, it was how often do you use, and I think it was daily, several times daily. But since I don't use daily, I wrote in, sometimes it's not even once a month, etc. So I noticed, you could write your own answer for some of them.
Yeah. You can tailor it according to your individual patterns.
And yeah, I noticed one of the choices for why was just to feel less crappy, which I thought was pretty funny. And I thought I saw that maybe on one of Dr. Kirsten Smith's, but I like that as an option because that's one of my reasons.
To be honest, I stole all of them from her survey.
Okay, yeah.
Yeah, with permission.
Stole it with permission. Okay. Yeah. How will the results be used? I guess, will you publish a paper on what you found?
Yeah, so I will hopefully have a biostatistician interested in assisting with looking at the data. But what I'm hoping to do is eventually maybe find some associations, some correlations between all this information that I'm hoping to gain, and then hopefully it can serve many different purposes. Primarily, myself being a clinician, I would be more interested in seeing perhaps, or getting more of an idea of what type of patient benefits from kratom, what type doesn't, who perhaps might require more of a screening for use, more of a different individualized approach, knowing that they are users, and more so to try and face who benefits and who may not.
The harm reduction paper, well, it's a review of literature. I notice like a lot of people just kind of in the abstract or in the introduction, they say the FDA has expressed that there's no evidence to indicate the botanical is safe or effective for medical use. Are there any botanicals that they say is safe for medical use, or do they just say that with everything that's not an approved drug? I'm just kind of wondering about that. Or is it just good to note that in any introduction about kratom?
Yeah, a lot of them do involve a little bit of a discussion on the FDA's position. You probably are more familiar than me on some of the legal battles over the past few years. If you were to ask me how, I know I'm going a little bit off topic, but how I feel about the FDA, I really don't think they have a good understanding of this botanical. I know they've been pushing for it to be classified and made into Schedule 1, which personally I after doing these type of reviews of literature and examining all the evidence, I really just don't think that there is sufficient and robust, clear data to justify that. I really think that classifying it as a control under the CSA would also hinder some of the research, and that's exactly what we need. We need more research into this botanical. We don't need to cause any further hindrances. But yeah, a lot of the papers have expressed the FDA's position, and I did include a little bit of that in my review as well.
Because I know they did, I think it was in the overdose paper, the FAERS database you looked at, and the suitors, and this was the reporting for kratom deaths. We've heard about limitations of the vaccine adverse reporting system. It's kind of like an open reporting system. Does that FAERS reporting system have the same limitations where it's sort of open and it's self-reporting?
I actually looked at several papers that were based on data collecting through different databases. That obviously includes the FAERS, the poison control databases, death certificates, and everything else. And with the FAERS specifically, there's only one that looks primarily. I'm not too familiar with how the reporting takes place into it. But the bottom line is that they found that the side effects that were quite serious, including deaths, and had kratom linked to them, did involve other substances, which obviously we know from other studies as well.
Can kratom still be considered causative even if there were other drugs present?
So that's an interesting question, because I think there's no universal standardized way to really report deaths that did involve kratom. They're looking at particularly the papers that examine coroner reports. It was interesting because you had cases where first of all, most, if not all, it did involve either co-ingestions that had respiratory suppressant effect, either prescribed medication or illicit substances. What was interesting to me is that there was no correlation between the actual concentration of the alkaloids reported in those death certificates when reported, and whether kratom was deemed to be the cause of death. So, for example, you would have cases where say one had extremely high mitragynine concentration, yet kratom was not deemed to be the cause of death. They claimed it was the other opioids that were co-ingested. And then you had cases where kratom was extremely low in terms of the concentration, yet it was deemed the cause of death. So there's really, I feel like it's not a universal standardized way that these information is being reported. It may just be left up to the individual medical examiner and coroner to determine. It's quite subjective, I would say.
You also mentioned in coroner's reports that the substance isn't tested very often, the actual substance they took. And as you mentioned in I think probably both of the papers, that you don't know what you're getting from one substance to the other. And then there's the extracts and the plain powder, and everything seems to have different alkaloid concentrations. Why do you think they're not testing the substances? Would it be maybe cost prohibitive to do so? Because it seems like we're not talking about the same thing across the board, and then there's a lot of contamination and things like that.
Right. I also something to keep in mind is that the reported concentrations are vary tremendously in terms of the timeline from when they were collected. You're right. They some of those laboratories don't report it primarily because you would have to have a high index of suspicion that kratom is involved to require testing, and also there's tremendous variation in terms of analytical modalities in which they're examining the alkaloids. Any other contaminants or anything else that may be present in the currently available kratom products, of course.
The 7-hydroxymitragynine, it seems to be more like morphine in a lot of even the animal studies. And I did interview Christopher McCurdy, who was on one of these papers, and he told me they've seen the levels of the 7-hydroxy go down in many of the dried products in the U.S. from what they were. And it seems to occur in very small amounts, but even in small amounts, does that pose kind of more of a risk? Because He also told me they looked at the some of the fresh leaf plants, which are used traditionally over in like Malaysia and Thailand, and he said they don't have as much of the or any of the 7-hydroxy in the plant. So is the amount of that might be a factor in how much risk for addiction there is?
Yeah, so obviously the animal studies that looked at individual alkaloids do suggest, as you put it, that the 7-hydroxymitragynine tends to act a little bit more like the traditional opioids, whether mitragynine does have some intriguing, at least intriguing to me, properties in the way that it interacts with those opioid receptors. I saw somewhere it actually helps in decreasing morphine intake, helps with various other aspects of addictive disorders. But as far as the addictive properties, and I'm sure my understanding is that there's two school of thoughts with regards to how 7-hydroxymitragynine is formed. Some believe that it is more of a oxidized product from the plant, whereas other believe that does require the type of metabolism that takes place in the human body for transformation, and that may be the active product from mitragynine. I'm not aware of any study looking at these products that we have here in the United States and how much variation there is in the mitragynine content.
How did you find that mitragynine compared with morphine in some of the animal studies? Kind of like a two-part question. And how indicative are the animal studies of what the substance is going to do in people? How do they translate into the effects on human beings, especially for addiction and dependency?
Yeah, so that's always an interesting question, and how you can translate information from animal studies to humans. And I think when it comes to kratom, we really don't know. There is some evidence, just focusing primarily on the opioid receptor. There is some evidence in animal studies. Mitragynine does have more of a partial agonist, or I should say, depending on the concentration, it's more of either an antagonist or agonist. Whereas in humans, it tends to be more of a partial agonist. So even at the receptor level, there's some differences there. In terms of translating this information, we really just have to look at it in a way that we take everything with a grain of salt. What was found in animal studies is that mitragynine the majority of them tends to prevent cross tolerance to morphine, and also when co-administered, it may even decrease the administration and decrease emergence of markers that are responsible for dependence. I'm intrigued by the therapeutic potential of mitragynine. When it comes to the risk for addiction, I think the 7-hydroxymitragynine is much more easily deemed as a culprit there because of its involvement, how it really provides the reinforcing properties. So if we were to have some type of analogy, I would probably, looking at the cannabis plant, I would probably look at mitragynine more like the CBD component, and the 7-hydroxymitragynine more as the THC component.
And I've even pulled out a quote here that said at the mu-opioid receptor, mitragynine has a much lower affinity compared to morphine, whereas 7-hydroxy has a much higher affinity than both.
Right. So even in the way that it binds the receptor, it's stronger.
It seems like in a lot of kratom, there's just not very much of it. But then you do see people that have addiction problems, so it has to be something that's going on there.
We're learning more and more about the neurobiology of addiction, how it really works, and how it can be applied to both addictions to substances as well as to behavioral addictions. It's really all about the circuitry that gets adjusted in your brain. I'm sure you would agree that some individuals do develop an addiction to kratom. These are the ones that I tend to see in clinical practice, and these are the ones that tend to have more of a moderate to severe use disorder.
Are those people generally, have they been addicted to like opioids in the past and then tried to switch to kratom, or are there a lot of people that just have never had an addiction and they started kratom and got addicted to kratom?
Yeah, I'm seeing a little bit of a mix.
Okay.
And if I were to categorize the type of patients who I'm seeing for both psychiatric and addictive disorders and how they interact with kratom, I think I can probably categorize them in two categories. The first one being patients who I'm treating either for psychiatric or addictive disorders, and they happen to at the same time consume kratom either due to a desire to self-manage various symptoms or improve their mental and physical health. That's the one category. And then the second category, which I would say is the vast majority of individuals, those are the people that present to me because they've had a hard time in quitting kratom, or maybe they started experiencing some adverse effect. Again, I see a disproportionate number of those who experience the addiction side. I can probably provide a bit of an overview of how such patient would present if we have the time.
Yeah. Yeah. Sure.
Okay. So what comes to mind? I saw this lady on an inpatient behavioral health unit towards the end of last year, admitted for management of bipolar disorder, and she was a kratom consumer and expressed a desire to get some help while here in the hospital. And she told me she started about 4 years ago. Initially was using just 5 grams daily in the morning, then started increasing it to 5 grams in the morning, then in the afternoon, and really over the last year, her use exponentially increased,
Mm.
slowly, very slowly, up to where she was using 18 grams every 2 to 4 hours.
Wow.
And yeah, sometimes she would wake up at night because she would have some sweats or restlessness and have to prepare a drink at night. Her finances started to suffer. She had switched vendors at one point and ended up getting a product that even she admitted it looked suspicious, and she ended up having two back-to-back seizures.
Oh, wow.
And her significant others have left her because of all these issues that she was having. She tried getting off of it on her own, did okay for a couple of days, tried to fight through the withdrawals, then went back to it. Primary care tried to help her with some supportive means, clonidine, antidiarrheals. That helped for about 2 weeks or so, but really the cravings and everything else put her back into using.
Mm.
But this is someone that's never had any type of addictive disorder. Like I said, she was using primarily for that energy burst. Part of what where I think we need a lot more research is who is vulnerable. We know that
Hmm.
in general addictive disorders, genetics play a role, early exposure, underlying psychiatric and other substance use disorders, and even someone that has a deficit in their reward system is more predisposed. But we definitely need more research to identify who is at risk for such adverse effects.
Yeah, and just addiction in general. I mean, I've read a lot of things about addiction that a lot of people who become addicted to any type of drug are trying to deal with past trauma, and like in particular, people have childhood trauma or prone to very severe addiction. Does that happen among a lot of your patients, or some of them?
Yeah, I think a lot of them have had some trauma histories, and that obviously predisposes to a whole range of psychiatric and addictive disorders. As it pertains to this I'm sure you've seen it thrown around. Kratom use disorder, KUD,
Mm-hmm.
which is not it's not actually recognized in the diagnostic and
Yeah.
statistical manual. Um, I um, I think the underlying processes, the neurobiological processes, is the same as for any other substance use disorder.
Mm-hmm.
I have all these classes of alcohol, opioids, stimulant, cannabis, tobacco, sedatives, all the way up to even caffeine.
Mm-hmm.
It's possible to develop an addiction to them. Some more severe than others. Obviously, the opioids have gained more of a reputation in part due to the deaths that have been noticed over the last years. But it's possible to develop an addiction to almost everything, including kratom through the same type of mechanism. All these substances do produce a surge in dopamine, which is
Mm-hmm.
one of the neurotransmitters in our brain, and the dopamine tends to have an impact on the basal ganglia, an area which really controls reward and our ability to learn things based on reward. What happens is this really provides more of an euphoric effect at first, but with repeated exposure, especially repeated exposure to high doses of anything that triggers this dopamine, that area becomes a little bit less sensitive. So you get less of an effect. That's called tolerance.
Mm-hmm.
And this type of circuits are almost the same ones that are activated by natural reports. So like exercise, food, anything that triggers pleasure. So when one is used to getting this activation from a substance, everything else in their life really seems like it's not doing the same. It doesn't produce the same effect. For one that does have more of a moderate to severe addiction, other parts of the brain are involved as well, including the frontal lobe, the prefrontal cortex, which regulates impulse control, our ability to use our values to regulate the decisions that we make. So it compromises that as well. So it's almost like imagine a car going downhill. You have your foot all the way down on the gas pedal, and you cannot push the brakes. That's what happens in addictive disorders, and it's the same thing with someone who does develop this addiction to kratom. It's now not entirely different than any other substances.
Do you have an idea of the percentage of people who use kratom who develop an addiction?
I believe I saw a survey that was done recently and was trying to collect a lot of different information. But one of them was how many of the participants would meet criteria for a use disorder
Mm-hmm.
diagnosis according to the DSM, the Diagnostic and Statistic Manual,
Mm-hmm.
and that number was 30%. But you have to realize that there's different levels of severity of a use disorder.
Mm-hmm.
So you have the mild, moderate, and severe. And most of these individuals that would have met criteria would fall more in that mild category. I guess it would be relevant to provide a little bit of background here on how we diagnose a use disorder.
Yeah.
It's based on 11 criteria that are put forth by the DSM. Let's see if I can find here my manual so I can tell you what these are. These 11 criteria involves, say, the first one is, do you find yourself ingesting the substance in larger amounts or for longer than you initially intend to? Second one is, have you found yourself wanting to cut down or quit and being unable to? Third one is, are you spending a lot of time obtaining, using, or recovering from the effects of the substance? Fourth, do you have cravings or urges to use the substance? Have you had any periods of time where, because of the effects of the substance, you are unable to perform at work, home, or school? Sixth, are you still using even though you know it may cause problems in relationships? Seven, have you given up important social, occupational, recreational activities because of substance use? Eight, have you used the substance even when it puts you in danger? Nine, have you continued to use even when you have a physical or psychiatric condition that is worsened or caused by the substance? 10, do you find that you are needing more of the substance to get the desired effect? And 11, have you developed withdrawal when stopping the substance abruptly? To meet criteria for a use disorder, you only need two of these.
Okay.
And this information is extracted more based on the interview with the patient. It's not like you would sit there and ask the patient these questions like that. It's more from the conversation that you have with the patient. You extract whether they would meet these or not. So, with Kratom, I think it's very easy to meet criteria based on the last two questions alone. Do you find that you are needing more of the substance to the desired effect? I know a lot of consumers tend to increase their consumption in the first few weeks or months. And number 11, have you developed withdrawal when stopping the substance abruptly? I'm sure a lot would experience withdrawal if they were to use daily, long periods of time and then abruptly stop. So it's not hard to meet the criteria for a mild use disorder. If you have 2 to 3 of these, then it would be considered more of a mild use disorder, 4 to 5 moderate, and 6 or more severe.
I know people who they seem to have tolerance and withdrawal and like anything that would meet constitute a physical dependency. Like with coffee, like I don't even use Kratom enough I've never developed a tolerance to it or increased my use. But with coffee, I quit for a couple weeks about a month ago because my blood pressure was going up, and I noticed that my sleep patterns were off. I was grumpy. I was getting a runny nose because I've drank coffee since I was in my whole adult life, pretty much. Well, I don't know if that's an addiction because I have but I think it might be a sort of a physical dependency, but it doesn't hurt my life in any way. My heart's fine. It's not ruining my health, and I feel like a lot of people have that with Kratom, and it's helping them, but they do have a physical dependency. I guess where's maybe the line between dependency that might be beneficial or a addiction that's harming people?
You are absolutely correct. There's the different layers of severity certainly tell us a little bit about the dangerousness. For example, with opioids, you can definitely see how one can easily meet at least 6 of the criteria. It's a serious addiction that leads to impairments in daily function in their overall life. Whereas, as you pointed out with coffee, and there is such a thing as caffeine addiction, sure, you can meet maybe only 2 of these and have a mild addiction to it. And going back to that study that showed that 30% of consumers do meet criteria. What is found is that indeed it's more of the tolerance and withdrawal rather than the functional impairment. And if I had to hypothesize, I would say that most who would meet criteria for Kratom addiction, the vast majority of them would probably fall in that mild, maybe moderate severity, with very few that fall in the severe category. But those very few that fall in the severe category, those are the ones that tend to get reported through case reports. Those are the ones that I'm seeing in general clinical practice. So that would be the breakdown when it comes to addiction to Kratom that I anticipate.
Do you treat Kratom addiction with Suboxone?
Yeah, so we published a paper on that back in 2019, I believe. It was intended to gauge how Kratom addiction is handled in the clinical setting. And what we did there is we surveyed all addiction medicine physicians, inquiring about whether they encounter patients who use kratom, whether they encounter patients who would meet criteria for an addictive disorder, and most importantly, how they manage it.
Mhm.
And a vast majority of them did answer that they are using either buprenorphine. I believe there was a couple that said naltrexone or Vivitrol. None have said methadone. But also contrasting this survey with the review of literature, what has been published, seems like it's along the same lines of using similar medications as those for opioid use disorder. I believe there was a case series from the Veterans Affairs where some patients were on methadone, and
Mhm.
I am personally aware of one case here in New Hampshire where there's a patient on a super low dose of methadone for kratom addiction.
Hmm.
Personally, if you were to ask me where the vast majority of those individuals with kratom addiction that is severe and requires pharmacological interventions would fall, I would say that the vast majority probably would benefit from buprenorphine. Some would also benefit from naltrexone, and I don't know about methadone. I guess if it's severe enough, it probably would be warranted. The lady that I mentioned earlier, the one case that I had here at the hospital, I ended up putting her on buprenorphine, and to my knowledge, she's done well.
Okay.
As I mentioned, she failed. Just supportive intervention, just simple detox did not work for her, given her severity of her addiction.
Well, I can already hear them saying it, but a lot of people would say, "Well, aren't you giving them a heavier opioid to treat the addiction? Wouldn't that be like treating caffeine addiction with cocaine or something like that?" Buprenorphine's also a partial opioid agonist, right?
Mm-hmm. Yep,
Okay.
very similar to mitragynine in the way that it interacts
Yeah.
with the opioid receptors. Very similar, yeah. That's a good argument and concern to keep in mind. But at the same time, I have to look at one's level of functioning.
Hmm.
For example, look at this lady that I presented. She's lost her significant others, having severe functional difficulties in her
Hmm.
life, financial challenges. She's had seizures due to the high. Probably due to the high mitragynine concentration in those products. So she's definitely not functioning well, and something has to be done. And if buprenorphine is able to help her stay away from any substance and be able to get her life together, what what can we do? We can withhold a treatment that can be life changing for her.
Yeah. But I noticed in the overdose paper, you found that the toxicities resemble toxicities from stimulants rather than opioids, and naloxone really can't be used to reverse a situation where somebody might be overdosing on kratom.
Yeah, that's an interesting concept there that we found, because initially a few years ago, I would say we all thought that the toxicity and overdoses are based on kratom's interaction with opioid receptors, but really all the evidence from animal studies, from presentations and various reports do resemble more of the stimulant effect,
Hmm.
more of the adrenergic effect that it involves, seizures, high blood pressure, involves more of the cardiac effects as well. Not so much the respiratory depression. In fact, some of those reports to the databases did find that individuals maintain normal breathing rate, normal oxygenations. So the toxicities do resemble more of the stimulant effect and not so much the opioid effect. I know there's at least two case reports that describe presentations where they tried to use naloxone and it had very limited effect. I would still endorse that. I would still endorse that presentation should receive naloxone, and part of that is because there's a lot of co-ingestants. Individuals who present under such circumstances ingested opioids along with kratom, and naloxone would definitely assist there. And there's no harm in delivering naloxone to someone. So if anything, it can only help reverse the opioid component.
Yeah, and I recently just ordered those naloxone breath things that you can get for free. I should actually put a link up at some point, talk about that. But
the nasal injector.
Those. Yep.
Interesting. A lot of people don't know, but you can obtain those through your local pharmacy. I know I've done quite a bit of this standing orders in the area where I would give a pharmacist the okay to dispense those kits under my name to anyone who comes and requests them. I'm sure it's
that's great.
It's in other states as well, but you can obtain one from the pharmacy without a script in some situations.
Yeah, there's definitely been the fentanyl overdose issue, and I'm in Pittsburgh, so in this area it's been pretty bad. I had one more question about the animal study. One of the studies that said that the mitragynine kind of primed the animal for an opioid behavior, and that would be a concern, because I really haven't looked into that much, that if somebody starts taking kratom, and since there's cross tolerance, would it make them more likely to take other opioids?
I think it was a drug substitution study where rats were trained to self-administer the various illicits, methamphetamines, heroin, trying to pre-treat that with mitragynine actually decreased the response rate that was maintained by heroin. So it found that mitragynine didn't substitute for morphine self-administration. But then they also repeated that with the 7-hydroxymitragynine, and it found that it had the opposite effect, as we expected based on what we know. It actually did substitute for morphine self-administration.
The one paper is called Kratom as an Opioid Alternative, Harm Reduction. Do you think kratom or mitragynine, maybe in the future when it's more studied, and could be a harm reduction tool? Because I think a lot of people have been successful using it, but it's probably too early for a psychiatrist or any kind of medical professional to say, yeah, go ahead and do that, because we don't know enough about it. Maybe I just answer your question.
It's if you look at the currently available FDA-approved pharmacological treatments, 60% of what we have, or 60 to maybe more, I don't know the exact number, but 60% of the currently available medications are derived from a botanical in some form. Looking at kratom, I personally believe that there is something therapeutic in the mitragynine component. I do have concerns about the 7-hydroxymitragynine and the impact that would have on patients, but I'm quite intrigued by the mitragynine. I would certainly love it to be studied more, so we can really understand who would benefit, what kind of conditions, what dose, what route of administration, for how long. I think we really need more studies on it. I use this analogy a lot. Has to do with the foxglove plant. When back in the day, they realized that it can have some benefits in individuals with cardiac conditions, and everyone was using it quite efficaciously until people started having very severe adverse effects, and they were able to study it more, isolate the active ingredient, and now we have digoxin, which helps a lot of individuals. It's available by prescription. We know about its safety. We know about what dose, what route, what conditions benefit for it, and I would be excited to see the same thing happen with kratom and its alkaloids.
Yeah, and foxglove is still illegal, but you should not take it. Well, thanks a lot. This is a great conversation, and it's good to talk about addiction with an addiction psychiatrist, because I know it happens, and there's a big political conversation around it, and we can't always get to an honest discussion without. So I appreciate your expertise. It's I hope it helps inform a lot of people.
Thanks for having me. I feel like there's always these two sides, the pro and anti-kratom sides that are quite divided, and we definitely need to figure out a way to work together so that we can better understand this botanical and see who benefits and who doesn't. And I think you're doing great job with Kratom Science, and I appreciate the opportunity to come on and share some clinical insights.
All right, thanks for coming on again, Dr. Cornel Stanciu. There's a link to his new survey in the description if you use Kratom. Follow us on social media, TikTok, Facebook, Twitter. Please like, subscribe, share, rate, review, comment, tell somebody about it. Music is Risey. The song is Memories of Thailand. Kratom Science Podcast is produced by me, Brian Gallagher, for KratomScience.com. Take a tolerance break every few days, and take care.